I had started by making the comment that my AMA days are well behind me, and I've moved on to a variety of other exciting, rewarding, and challenging work opportunities, and I see my involvement with Telelcare provides one such opportunity. However, having said that my AMA days are well past me, I would nevertheless like to introduce this session with a reference to the recent Canberra Press Club address by Dr. Omar Khorsand, who's the federal president of the AMA. Dr. Khorsand spoke of AMA's vision for Australia's health and of the 5 pillars necessary to support this vision. Last but not least was Pillar 5, a health system for the future. And I quote, embracing new technology and innovation, consolidating the gains from COVID-19 reforms, and building upon them to facilitate better access for all patients and a great understanding and engagement between patients and practitioners. It will also require better use of data and technology to aid diagnosis, clinical audit, and patient engagement, and to provide solutions to deliver care in circumstances currently not possible. Key to consideration of a future health system are the opportunities offered by new innovative models of care, integrated care at a lower cost, and value-based healthcare. That is sustainable system redesign. And that leads me nicely into the first session this morning, the future of collaborative care post-pandemic. It's with great pleasure that I introduce our 3 panelists for this morning's session. First, we have Dr. Karen Price, who you will see on the screen. Karen is well known to attendees as the current president of the Royal Australasian College of General Practitioners. We are fortunate, I expect, and privileged today that she's found time in her busy schedule. Certainly, although I've never met Karen, I've seen her at TV appearances and applauded them on a number of occasions, particularly speaking with matters relating to the role of GPs and in the COVID vaccination program. As a former general practice owner, RACGP, I'm sorry, Karen, Victoria Co-Deputy Chair, Chair of Women in General Practice, and a practicing GP for more than 25 years, Karen came to the role of president with plenty of experience under her belt. She is passionate about GPs thriving through effective communication, good governance, teamwork, and patient safety, and providing the profession the support it needs to carry out the purpose of its work: high quality, holistic, and longitudinal patient care. Every day of Karen's presidency has been dedicated to getting GPs the resources they need, you need, to do the job you are trained to do. So if I move on, my intention is to mention the 3 panelists up front, and then we'll start the discussions. The second panelist is Dr. Bernard Shiu. Dr. Bernard Shiu is the current RACGP Victoria Co-Deputy Chair. He's also the owner of a medical practice in Geelong, and he was named the GP of the Year in Victoria in 2020. Congratulations, Bernard, for that, for his involvement and contributions to multiple official government leading committees during the pandemic. Bernard is completing his MBA degree at Harvard Business School and is known for his innovative thinking in business strategies. He is one of the first GPs who adopted telehealth in Australia long before the COVID-19 pandemic. His medical education and training has led him to work across the USA, United Kingdom, and healthcare and Hong Kong healthcare platforms. Bernard's main research interests have been around medical education and children with mental health issues, and recently he has been heavily involved with research and management of long COVID, while sitting on the advisory committee of the National COVID-19 Clinical Evidence Task Force. Welcome, Bernard. And our third panelist is Dr. Christopher Sia. Chris completed his Bachelor of Medical Science and Bachelor of Medicine and Surgery with honours from Melbourne University. He then went on to specialist physician training, obtaining the top score for the RACGP written examination. Congratulations, Chris. And then completed his advanced training in nephrology. Chris's interests include hypertension, chronic kidney disease, dialysis, and transplantation. He has a public hospital appointment at the Alfred Hospital, where he works in these areas of transplantation, dialysis, and general nephrology. This public hospital appointment allows Chris to stay up to date with the most recent developments in nephrology and gives him the ability to care for all his patients through the journey of chronic disease, chronic kidney disease, dialysis, and transplantation. Chris also, as previously mentioned, has the vital role at Telelcare as our Chief Clinical Officer. So clearly, we're extremely fortunate that we have three outstanding panelists to deliver this first session, titled The Future of Collaborative Care Post-Pandemic. Can I just remind the attendees again that if you've got any comments, please add them to the chat facility which you'll see on your screen. I'll endeavour to monitor these and likely we'll address them at the end of the session rather than during the presentations, but I think we can have some flexibility about that. Let's start the ball rolling with hearing from each panellist on their experiences during COVID-19. Karen, Dr. Karen Price, if you'd be so good as to start this off. Thank you very much.
Thank you, Robyn, and thank you to my fellow panellists, and welcome to everybody. And I salute your commitment to medicine on a Saturday morning. I'd also like to acknowledge the traditional owners of the land on which I record this message, the Wurundjeri people. I pay my respects to their elders past, present, and those who are emerging as leaders. I also recognise that in Aboriginal culture, health does not just mean the physical well-being of an individual, but the social, emotional, and cultural well-being of the whole community. And that aligns with the 1948 World Health Organization definition of healthcare. And as a generalist, and for most of you who are generalists out there, that's a really important paradigm that we need to address in this world of data. I'm a GP myself who has been working on the front line through the telehealth, and I would like to say that telehealth is not a new innovation. Where the innovation has been is in the funding model, and that's what we've seen. For as long as I've been a GP, we've been using the telephone, and as many, for my case, being a part-time practitioner when my children were growing, it was often very useful to have other modes of technology to maintain that continuity of care and ensure patient safety. So we're early adopters of technology, and the funding has lagged behind, but now we've got a good nexus for us to go forward. In terms of my experiences of telehealth during the pandemic, quickly became obvious this is a fantastic way for many of our members who suffer chronic health conditions to keep themselves safe. We know in general practice, the provision of PPE wasn't as well as it was in hospital. I've got a daughter in physician training, Christopher. I might get you to tutor her. You know, it's I saw what happened in the hospitals, and you know, we didn't get the same consideration out in general practice. So for doctors who had chronic health conditions, and I think I can't remember the number, Bernard, but it might be between 25% or so of people who had chronic health conditions who needed to isolate themselves at home. So this provided a way for continuity of care, which was fantastic. So personally, as a clinician, patients who were also afraid, trying to make sense of what was happening to us all, many of them stayed home. It became a quick shift to working out how to conduct patient care using telehealth. What became obvious to me as this progressed in this iterative way that we did was that knowing your patient well was a great augmentation to providing continuity of care in terms of understanding their health needs, understanding who you were talking to, and understanding how they're going to receive the health message. If ever I had a new patient, it was a much more difficult process to actually manage their health care. So that was a key learning. The other key learning was that as the we know the stats that as the shutdowns went on, we had huge uptake of telehealth, and as the shutdowns came off, then people returned to face-to-face. We know that people in general practice in particular, and probably in hospital specialist care, people prefer face-to-face overall, and this is an augmentation of usual care. So because relationship care is what we do. So the other thing I noticed was that patients who were most burdened by perhaps mental health issues or particularly chronic complex medical care, and our vulnerable patients, the inverse care law still applied, and these were the patients who seemed to remain on telehealth much longer than those who were more mobile and had more personal resources themselves. So now I've got quite a few patients who've still got chronic complex medical conditions, who've got severe mental health, who are using telehealth. And this has been represented from people I've spoken to in AIDA, the Australian Indigenous Doctors Association, who've talked about this. Dr Sarah Chalmers of ACRIM has talked about this. Remote and rural patients who've got high vulnerability have found telehealth to be wonderful. So that's where we're up to, and we've got the on and off again kind of moments of the government funding, which makes it very difficult, but we keep adapting because we are doctors and we're good with resources and trying to have plan B, not only plan B, but plan C and D, although no more C's and D's in telehealth for phone use. So what did the RACGP, how do we advocate in this realm? Well, of course, we've been talking about telehealth, and the salute Bernard for using the platforms well before. We got the telehealth up and running. Of course, it was mandated bulk build, which was a bit of an issue for us. It was great to have that released later on the year. That didn't happen in hospital practice, I don't believe. We also it became very obvious that the merchants of medicine were out there, and that we had a corporatised model to raid Medicare funding and taxpayer funds. And so this is always going to be an issue for us in healthcare. We've got to maintain our professionalism and advocate in a way that provides a professional level of service and not a merchant level of service, which is tricky because we've also got to provide funding for our clinics and for ourselves in a professionals with our professional services. So we've now got a situation where the government has actually removed some of those C's and D's, as I've said, and ring fencing the telehealth has meant that we've also blocked off some of the more subtle parts of medical practice. So I presented with Danielle Matzer, Professor Danielle Matzer of the Centre of Research Excellence in Women's Health at Monash University. She's got a great study showing the reduction of access for women for reproductive services and abortion care, particularly medical abortion in rural areas, and that was an exemption that was basically put through on the evidence. There was also a political issue there with the smoking and vaping groups. So there's an item for a loss of for a removal of the face-to-face requirement for those people. And we also got the pregnancy counselling, which was important. And Jean Hales also helped with us to advocate for sexual health for women who've got menopausal issues who may not wish to talk to their usual practitioner in rural and remote areas of Australia. And they like to talk to Jean Hales, general practitioners. So there's some very niche areas. And it's been a very difficult navigation. I do believe towards the end of the year, we might have another discussion. This is an iterative issue. I can tell you that the Department of Finance and Treasury are terrified of telehealth because it's uncapped Medicare funding, and we've got to be able to work with them, not harming patient care, not harming the tax base. It's a very complex discussion, and it's more than just the Federal Health Minister. It really is the whole of the Canberra bean counters and so forth who are trying to maintain a functioning health system within a certain remit. So, it is a complex discussion that we're having. We have got now with telehealth, we've got the ability to do remote consulting, and I'm so fascinated to hear the later presentations by Raymond and congratulate you on particularly thinking about rural and remote health and looking at how that will work. in my practice, I've absolutely loved e-prescribing because it's fantastic. I talked through a patient who was coming out of hospital, a 93-year-old. I talked her through receiving an e-prescription, and it came through on her mobile phone because so many people have their mobile phones. And she was absolutely thrilled that she was now a techno girl and could take that, give that to her son and take it down to the chemist. And this has meant that I've been able to, perhaps provide continuity of care. Even as a president, I can do that in between times. I can get remote access to my clinic. I can do e-prescribing. I can still maintain that care. So for me, as a person who's got a lot of demands on my time, that is fantastic, and it saves another practitioner having to work out through a complex consultation. It takes me 5 minutes because I know my patients well. We've also moving within e-prescribing to active script lists, and I had a chat to Emma Hossack, the head of the medical informatics groups, and it's going to be an interesting area where this is going with the e-prescribing will hopefully help us develop some active script lists, which means patients will sort of know what they're using through this modality. Whether that will change the sort of use case of My Health Record, how that will fit into this interoperability that we're all trying to work towards, I don't think we're quite there yet. The My Health Record has still got a patchy reputation. It is clunky. It doesn't really integrate with my particular software, but I know that the hospital doctors use it a lot to try, and especially the younger ones, Chris, who use it a lot to try and check patient prescription lists and so forth, which is really important. So there's going to be this, it's really messy. And if you read Tricia Greenhouse, Professor Trish Greenhalgh from Oxford University, a primary care researcher, talks about complexity theory and how we'd love to have a linear way through, like open this door, take step 1, take step 2, take step 3. But this is complexity theory, which means we have to muddle through because there are lots of innovations, and it really we have to work through how they work, this interoperability. We know that's the destination. I don't think we're quite there yet, but we're much closer than we were even a year ago, maybe even 2 years ago, definitely. So e-pathology, e-radiology, and of course we mentioned the collaborative care. This is a big push in our primary care reform groups that we're talking politically, where there is an appetite for investment to have one healthcare system. This is brilliant. This is about making sure we don't have this federated. We saw what happened when the federation breaks down this week. I know I've still got a headache from it. When we've got, healthcare for the hospital stops at the hospital door, and then it's a big black box of primary care. And for us, the same in reverse. We've got all our primary care hospital, if you like, in a distributed fashion, and then it stops when people go into the hospital into the state hospitals. So we want to be able to, in that collaborative model. We know primary care, we've done our PricewaterhouseCoopers modelling, we know we save the healthcare system huge amounts of money by doing preventative care. We know that if a patient, for instance, sees their GP within a week after discharge, it's a huge influence on them not representing and not bouncing back into hospital. And every time we do that, it saves the hospital system $11,000. So we know we provide best bang for buck. That's the World Health Organization. Sorry, Chris. We want to stop them ever getting to you. That's our job, and we do it really well. We've got to watch the primary care paradox. There's this tension between providing highly specialised care, which is very necessary, with the generalist care where you've got multi-morbidity. We know that generalist care actually produces better outcomes. So it's a very complex discussion. I didn't mention in my introduction that I've basically got my PhD written. I've just got to edit it, and that was on looking at connections and relationships and how they work to enhance patient care. So a very big interest of mine to work across those paradigms. So I note that Omar at his press club address talked about data. And I do want to talk about this because this is a really important point that I keep banging on about. So forgive my ear bashing, but data. I want to ask which data. When we talk about data, and I say this in every government meeting, they usually only talk about big data sets and quantitative data. And there is a whole world of qualitative data, which is very important. And if we're going to put our patients at the center of this conversation, not e-health providers, not physicians, not all of the government instrumentalities who like to use big data sets. We must put the patients here. So we've got to look at not disease-specific data points only. I mean, it's very important. I love randomized controlled trials and meta-analyses and all that stuff, but we also have to look at the qualitative data about how this is received, and we've got to put our patients at the centre. And we know the quadruple aim of healthcare is absolutely vital to consider, and we've done that in the Primary Healthcare Task Force Reform Committee. I've made sure they've got that 4 pillars on every bit of reform, which is the patient experience of receiving healthcare. It's population health outcomes, of course. There's the dollar efficiency, which means general practice is always the winner. And there's also the doctor experience of producing healthcare. We can't have burned out doctors, and I don't want technology to harm patients or physicians in that very fundamental relationship, because it is the relationship between physician or clinician of any sort and patient that drives the outcomes of healthcare. So I love technology.
Thank you.
Yeah.
Thank you, Karen. I think that's a very good point, actually. And there are certainly some issues that you've raised. But at this point of time, I'm actually going to pass over to Dr. Bernard Shiu, and again, ask him if he could go back to talk about your experiences during COVID-19, and then something about digital tools that are available to support GPs in their consulting, particularly. I think one of the things I picked up, Karen, was that there is a difference between the metro services and the rural services. And there is however much we might think face-to-face is the preferable means, it's sometimes simply not available, particularly for specialist care in rural areas. So Bernard, a bit about your experience first, and obviously you've been right at the forefront of this, and we heard that was well before COVID-19, so you're a real leader in this. Over to Dr. Bernard Shiu.
Thank you, Robyn, and good morning, everyone. Hi, Karen, that was amazing opening. Thank you so much. And we can see there are a lot of politics behind a lot of things that you have to do and will have to do in the coming years, and thank you in advance on all the things that you're doing. And COVID-19 pandemic has caused a significant disruption, for sure, to the delivery of care in our community, and be that metro or rural. As a result, healthcare rapidly evolved and developed and implemented to this new shifting ground, and model of care, especially the mobile delivery, has changed quite significantly. And in 2020, telehealth and what we call the digital healthcare became widely used in Australia, and having evolved from before pandemic was sporadic use, if you can put it that way, and to now becoming the mainstream. Phone consult, video consult, e-scripts, even a lot of the apps on the phone become our day-to-day practice. And if you look at that, and Robyn mentioned I've worked in many other countries before, and telehealth actually been a common practice in the UK and in the US, and in Australia it is still relatively in its infancy. So, well, I'm Bernard Shiu, and I am speaking on the land of Waterrun country in Geelong, and I would also like to pay my respect to the elders past, present, and that are emerging. And I own Bangkok Medical Centre and in Geelong, and started telehealth service roughly about a year and a little bit over before the pandemic started. We offered the service mainly for our patients who were working in remote area, interstate, and just want to keep a close contact with their GPs. The service mainly for prescriptions and also for mental health support, and would do CBT on them over video or over the phone. The service was not Medicare rebatable, but the patient were more than happy to opt into the service and did not mind to pay and have that connection with us. We made it very clear to them what type of consultations would be appropriate and what type of service would not. And obviously, some patients will be wanting to push the boundaries of that. And it's a learning experience for both of us to find out what works, what doesn't work. And so we used to use a very elementary technology called Skype. And many of you probably have used it before when we were younger. And so Skype is actually not that popular as a tool to communicate these days, but that's what we were using, a Skype business account to connect with our patients. The video quality was inconsistent, and because many of the patients were working in remote areas, and the scripts generated had to be faxed to their local chemist, and provided that we had a previous arrangement and agreement with them. Referral to any other investigations like CT, MRI, and ultrasound were very challenging, and that's just almost no way that we can arrange those. We try to incorporate a My Health record to facilitate this process. However, the usage by other providers, especially interstate and rural areas, were quite disappointing. So ended up hardly ever used the My Health record. When the pandemic hit us, our clinic, yes, was quite prepared because we've been using this. We just had to rapidly scale up the service and to match the demand that were coming from our patients. Interestingly, patients continue to want to pay for the telehealth service during the compulsory bubble phase enforced by the government. And many of our patients actually found it uncomfortable not paying and wanted to find a way to pay. And it's a very interesting phenomenon. During the explosion of this demand and rapid adaptation to this new cadence of digital platform, we explored other technology, including WhatsApp and CodeView and even Valio, bearing in mind that necessary data encryption requirement from the government. But due to the difficulty of securing a smooth video consultations, most of our doctors resorted to using just traditional phone consult with our patients. So I did a survey on our item numbers, and we found that telephone versus video consultation ratio was 98% versus 2% in the last 6 to 9 months. And I think this numbers and the data is consistent with what the college and also Department of Health have collected nationwide. So at the time, I bought each of our doctors a new mobile phone with unlimited SIM cards to make sure that they have credit to talk to our patients anywhere they want to work. So be that in the clinic or at home when they want to work not in the clinic. And overall, the patients and the doctors still prefer to use a voice communications, although the phone came with the capability of doing the video consult with them. I see this is our opportunity to rapidly advance healthcare delivery in Australia, from siloed management of care in certain privileged groups to comprehensive patient-centered care to all Australians through the use of technology. The system needs to recognize complex and interacting healthcare needs, which will maximize community participation, and that will improve health outcomes. Of course, the ultimate gain is a safe and high-quality modern healthcare that belongs to Australia. The technical constraints and limitations need to be worked through and well thought of. Otherwise, we're all just going to be stuck in this, it's just too difficult phase. And the habit that we have created in the last 12 months among the healthcare workers and also with the patients need to be addressed. Otherwise, again, the phone consultation will remain the prime choice, and it may just become the only choice that we have. On top of that, what I've been doing the research on is about the long COVID. There is an urgent need to comprehensively and longitudinally understand the long-term strategies, how to deliver care after the pandemic. Although long COVID appeared to be mainly talking about symptoms like fatigue, headaches, breathlessness, things like that. However, the COVID-19 report coming out is actually talking about multi-system symptoms in their recovery journey. These require community surveillance, multidisciplinary care, and coordination. So far, we're just focusing on mainly symptoms management. However, the impacts upon function, disability, and quality of care or quality of life yet to be fully understood. And also, of course, the psychological impact and the consequence may have full and profound impact on the individual recovery and the society as a whole. The preliminary data coming out from the Western Health indicates that people with COVID-19 experience significant and more difficulty with self-care, from hygiene to dressing, eating, or even just staying alone by themselves. And that really affects their relationship with others. Many find it hard to return to their pre-pandemic job duties or even maintain a semi-normal existence. All these are actually within the realm of general practice and require skillful and intentional surveillance managed by our GPs in order to reduce risk and improve quality health. Where do we go from here then? We need more study and to quantify the benefit of telehealth holistically via both phone and video. We need more fundings to encourage innovations and modernization of model of care delivery. Having an experimental mindset will help, and welcome new technology and approach or new approach that is coming up on the market. We need more IT support to make sure that remote communities, residential aged care facilities, and it can maintain their connectivity. I would like to hear from Sachin later on what he has to offer. And clinics need to have better infrastructure to support and support from the government to tackle this future challenging and ever-changing landscape of general practice. So that's all I have to share with all of you. I hope that makes sense. And once again, I thank you for your time today to allow me to share my thoughts. And I look forward to hearing from all of the experts today. Thank you.
Thank you very much, Bernard. Can I just ask you if you'd address one particular question which has arisen? It's about GPs working from home and access to patient medical records. Did they use remote login? If so, which application did you use? Now, if you're in a position to answer that, I'm sure it would be of interest to a large number of our attendees. Thank you.
So currently, my clinic use a remote login access to a central mainframe server that is sitting in Melbourne, so they can work anywhere. The only restriction has to be in Australia, so they can sitting on a beach in Gold Coast and still have access to all the patients' data. And that's what we're doing. But we are hoping a true e-health platform, which is totally not via a remote access window, but in fact, it's actually just from a web browser. If we can just access all the patient data, that would be ideal. At the moment, the two main healthcare platforms for data access for GPs are working on it. I know medical director has Helix that's actually come out and it's working okay, but I'm looking forward to best practice version of which is called Titanium, I think. And so that has been on the market on the testing phase, but it's not rolled out yet. So yes, the platform is just using remote access at the moment.
Thank you very much. I'm sure that was of value, that response, comprehensive response to the value to the panel, to the member who's asked for that information. Let me move on then. Thank you very much. Let me move on to our third panelist, who is Dr. Christopher Sia. Chris, again, if you could go back, Chris, as distinct from Karen and Bernard, is obviously looking at it not from a GP's point of view, but from the specialist involved in the total holistic patient care. Chris, if you could go back and talk about your experiences during COVID-19, and then you might be feel able to advance on to how can we use digital technology to promote collaboration and help patients with chronic complex conditions in the future. So over to you, Chris. Thank you very much.
No worries. Thanks for the introduction, Robyn. So my name's Chris. I'm a nephrologist. I work at the Alfred Hospital mainly. Today I'd just like to share a little bit about the experience in the renal department at the Alfred Hospital and what's been happening pre and post pandemic. So prior to the pandemic, all of our consultations were face-to-face. But since the COVID-19 MBS item numbers have been introduced, that has opened up some opportunities to do some telehealth consultations. And we, at the peak of the pandemic, we pretty much changed 100% of patients to telehealth. And when things settled down about 4 months later of lockdown, interestingly, we didn't go fully back to all face-to-face consultations, and we actually made a conscious decision that for various clinics we do different things. So for our transplant clinic, where we review all of our kidney transplant patients, I would say about 80% of patients continued on with telehealth, and 20% or so we went back to face-to-face consultations. And with the general nephrology clinics, it was probably more like 50-50, 50% telehealth and 50% face-to-face. So even though we're out of lockdown and we can do face-to-face consultations, we have made the decision to continue on with telehealth because we've seen the benefits. And I think the reason for the difference between the two clinics goes back to something that Karen said about how it's really important that you know your patient well, and how that's a big factor in determining the success of telehealth. So with the transplant patients, we know these patients really well. They come back to us frequently. And we have that existing relationship and rapport with them. So it made sense for us to continue telehealth. But with the general nephrology group, we don't really know them as well. And so that's why a larger percentage of them were face-to-face consultations. So what have I learnt? Well, there are definitely benefits and cons with telehealth. And so firstly, with the benefits, a lot of patients love it. I don't know if you've ever tried to attend a public hospital outpatient department, but essentially everyone's booked in at pretty much the same time, and there's a big pool of patients, and then you just work your way through them. And patients could be waiting 5 minutes, or they could be waiting 3 hours. And the telehealth experience for patients means that they don't have to wait in a waiting room for multiple hours. They don't have to travel, so it's much more convenient for them. So patients love it. Secondly, clinicians, as a clinician with young children, I love it as well. Sure, there are challenges, but being able to work from home is definitely a big benefit. So I think a lot of our clinicians secretly really did like working from home, as much as they may not want to admit it. And thirdly, what I've learned is in many ways it's safe. There is a misconception that it's inferior, but I think what I've learned is for maybe 80% of renal presentations, you can safely and effectively do telehealth. All you need is a home blood pressure monitor, and for most of these consultations, you can effectively do it. That's not true for dialysis patients, for example, in which examination is really important. But for most presentations, it's possible. And in some cases, it's even better. And this is perhaps has got something to do with the collaborative care model, which I might talk about a bit later. So what are some of the challenges that I've learned with regards to telehealth? Well, I think establishing rapport is very important, and it's a little bit difficult via telehealth. I think when you see someone face to face, you instantly have that rapport. But when you call someone up on their phone, that rapport isn't there, and you need to take some time to establish it. They may be in a car, they may not be ready for your call, and you need to give them time to realize who you are and maybe go through some of their medical history and just spend that extra few minutes to establish the rapport with patients. Other challenges are the whole issue of examination, especially in dialysis patients, which just is impossible sometimes. And the other thing that I've noticed is I can think of a few patients where diagnoses have been missed and or delayed because I think of telehealth. So I remember a transplant patient who presented with this massive fungating skin cancer on her arm, which had metastasized by the time she presented, and she died shortly after. And if she had come to clinic and seen us face to face, we definitely would have seen it. And we probably would have smelt it when she went in the room. That's how bad it was, but she'd just been ignoring it. And so it just makes me think that perhaps this woman would be alive today if we were seeing her face to face. So there is definitely that risk of delayed presentations or misdiagnoses with telehealth. I'll briefly touch about collaborative care, which is, and I'll save a little bit for discussion later, but it is one of the things that I've learned through COVID-19. The idea that specialists and GPs working together to achieve the best outcomes for patients. I think as a specialist, I've learned that I may be the specialist in my area of discipline, but I'm not the patient's specialist, if that makes sense. So I don't know the patient as well as their GP would for the majority of patients. So in a sense, the GP is the patient's specialist because they specialize in the care of that patient. And one example I can think of is I remember having a phone conversation or a video conversation, sorry, with myself, a patient, his daughter, and the GP. So the three of them were all present in one room. And as part of the investigation for chronic kidney disease, I noticed they had quite a large paraproteinemia. So ordinarily, I'd refer to hematology. I'd get a skeletal survey. The hematologist might get a bone marrow biopsy, and I may even organize a kidney biopsy. And so obviously these are very invasive procedures. And but we were able to make this decision really quickly with the GP and the next of kin and the patient that, look, Bob's quite frail. Management's probably not going to be affected. The chance of this being significant is low. Let's make the decision not to investigate. And that decision was made really quickly. Whereas I think if we had been doing this in a standard model, there would have been a lot of back and forth, a lot of uncertainty for the patient. And we definitely wouldn't have achieved this decision as quickly. So in this way, it's one of the examples that shows me that, hey, this telehealth model, this collaborative care model is in some ways better. Because with this face-to-face model, you can't have this real-time discussion with the GP. You can't have everyone in the same room at the same time. And I've noticed that really does lead to benefits in certain situations.
Thanks, Chris. We'll come back to you later for a bit more discussion about the collaborative care model. Thank you very much. There's been some questions and some discussion on the chat regarding confidentiality of documents and is it legal appropriate to email patients' pathology, radiology referrals using generic Gmail. Now, Bernard, I noticed you've responded in writing to that. I think it, would you be so good as to actually speak to that briefly? Because the chat moves so quickly. I think there are a number of people who are attending this session who would be very interested to hear what you have to say on that. Thank you.
Yeah, so I guess because it really depends on your IT skill and whether you actually outsource your IT support to another company. And so what we did was from the very beginning of me taking over Banksia practice, we decided to go on cloud. What that means is we'll have remote access wherever we go. So we actually hire a company to help us to set this up from the beginning, from the first day when we use best practice. So everything was actually set up on a server that is not sitting in our clinic. And so from then on, then we just have to make a decision of which platform to use to access the server. So the ones that I put on the chat were the two platforms, which both of them are Microsoft-based platform to use. And one is desktop, remote desktop, then that you can use from the phone or from iPad, from any of the laptops that you access. And in the clinic, we have clinicians that use Mac, we have clinicians that use PCs, and the same thing. It's kind of like a window. You open up the window, you maximize it. You wouldn't notice the difference that you're actually accessing another computer that is sitting in Melbourne. So that's what we use. And I'm sure there are other platforms that can do the same thing, because that digital platform is really just kind of like a little channel for you to access the information that is sitting somewhere in a secure server.
Thank you very much. The assurance being that it is sitting in a secure server, and so the issues about loss of patient confidentiality. Now,
Yeah.
Karen, you're sort of nodding at that. Have you got any comment?
I have to nod because the idea of a secure server is a fraught one, because it depends where the server is located. I mean, whether it's Australia or America, it'll have the certain legislation around it. So we've got to be really careful. How do I know this? My husband's an IT executive, and has worked on the AIHW sort of crypto security stuff, and it's really challenging to get that right. So when people come up to you saying we've got a secure server, you really need to get an expert IT person who's expert in cybersecurity. I don't think that a lot of well, it is happening now. I think there's thought being given to the need for protection of healthcare data, which is actually different even to financial data. So this is it's a very complex area. I don't pretend to be an expert. I just know, hey, Dunning-Kruger's operating here. I'm going to step out of this. Someone who's really expert, not just in IT, because an IT person will have an idea of it, but someone who's actually very specifically trained in cybersecurity and managing patient safety data. But of course, the correlate of that is that we don't want to make it so difficult to access. So it's a really complex, IT, issue, and I think we've got to make sure that we've got that right. So when someone says, "Oh, it's in the server," you just got to check what that means and what jurisdiction in particular where the server is, because that's where the privacy and the legislation sits.
Thanks, Karen.
Completely agree, Karen. Can I also make one more comment? It's where the server sits, and also there is another bit in the background, which is the backup server, because the server is being backed up live every second to another place, which is also very important, because if somehow the building got flooded in Melbourne, so we will lose all the data. So the company that we used, it's using the RACGP standard for encryption and also for the accreditation process. So hopefully that is exactly what Karen was talking about. It should be good enough. And the backup data center for us is actually in Perth. So even if Melbourne were to completely collapse, then we still have the back data. But again, it has to be within Australia, which is the standard at the moment.
Thanks, Bernard. Thanks, Karen. Can I suggest that maybe that's a whole new topic for the next webinar that Telelcare might be thinking of running? It's the whole issue of patient confidentiality when you go into electronic communication is so complex. And I think, Karen, we might have to call on your husband to help us as one of the guest speakers for that. But putting that aside for the moment, the other thing that's arisen in the chat is some concerns about the challenges of telehealth, the technical aspects of it for the elderly patients. Now, rather than anyone might like to make a quick comment on that, but the next session for this particular webinar is actually focused on aged care service delivery. So I think maybe we defer that to that discussion. I like the comment from somebody, and I must say it could probably be me doing it, of one of the patients holding the phone to their ear when it was intended to be video conferencing or video consult. Okay, so I will move on. We've sort of jumped around a fair bit, but I think incredibly interesting commentary from all. I really want to get back to this issue of collaborative care, chronic conditions, how we actually integrate the specialist services with the general practice services and with the patient. Now, I'm not sure, Chris, would you be happy to lead this off, or is there someone else who'd like to start it?
Yeah, I'm happy to speak about it. So the idea of collaborative care, which is GPs and specialists working together. I think it might be a good time for Sophie to bring up the slides. I'm not sure if people know about these item numbers, but and these are slightly old because they haven't been indexed for 1st of July. But I didn't know about these item numbers until recently, but essentially for rural GPs, rural patients, and nursing home patients, there are item numbers for facilitating telehealth consultations with specialists. There are certain rules, like you've got to be 15 kilometres from the specialist and have to be in an RA 2 to 5 location. But if you're a GP and you sit in with a consultation with the patient for a specialist via telehealth, there are some item numbers that you can bill. And interestingly, there's also an item number for the practice nurse to help facilitate as well. There is also an item number for nursing home patients. If you go to the next slide, please. So, even if in Metro Melbourne, Metro Australia, if the patient is in a nursing home, the GPs can facilitate these consultations, and the remuneration is reasonable, I think. You get a bonus for if you only see one, if you only do one telehealth consultation, there is a bonus, and that bonus reduces if you're stacking more and more telehealth consultations together in the one visit. So that's something that helps GPs and their practices with this collaborative care model. Currently, I think thanks, Sophie, you can take that down. Currently, I think the model, I think we've all alluded to, is very fragmented, and Karen mentioned that GP land is a bit of a black box, and I'd agree with that. And sometimes I wonder whether hospitals are a bit of a black box for GPs as well. I know as a specialist, trying to access information and results from a different hospital is really tricky and time consuming. It's possible, but it's time consuming, and which, we just don't have time for. And I presume it's going to be the same for GPs. And yes, there is my health record. I think one of the main issues is uptake of it, especially specialists and working in private practice. It's just not something that's commonly done. Even in public hospitals, it's not something that's commonly done. And it's one of the frequent complaints I have with patients. They will complain to me and say, shouldn't you have all this information? It's my GP would know. Shouldn't you know? And I say, yes, I should, but I don't. And that's one of the frustrations. So I think going forward, it would be nice to have some sort of portal or some sort of technology that would allow GPs and specialists to communicate better. But moving to something a little bit more practical and speaking a little bit more about my experience as a specialist, I have had multiple phone calls which are facilitated by the GP, and I'll give you one example. So there was a nursing home patient that I remember speaking to, and we actually did a 4-way conversation. So it was me, the patient, the GP, and the next of kin. They had quite advanced kidney disease, and we were able to make the determination in that consultation that the patient really, it's not appropriate to have dialysis. And to me, it was really good that we could establish that just after one consultation. Usually, you need to spend multiple consultations to get to that point, because you need to get to know the patient, you need to establish the rapport. But the advantage of having the next of kin and the GP all in the same room, these people already have that rapport with the patient. They already know the patient and their comorbidities and their frailty and their wishes. So you can make that decision. I provide the medical specialty advice. This patient or patients in general won't benefit once they're above a certain age or have these comorbidities. But the GP and the next of kin have that knowledge of the patient, that long-standing knowledge of the patient. So the model where we can all get together in one virtual room and make a decision is really beneficial. So I might pass it over to Karen and Bernard to continue the conversation.
happy to talk about this. This is a really big emerging area. This is a big emerging area, and I really want general practitioners to pay attention to this politically and from a funding point of view. In the UK, they have what's called managed clinical networks, and I know that with my mate, Professor Chris McCormack, who's head of the melanoma unit at Peter Mac, we've been trying to work out how can we reduce the presentation of some of the sort of melanoma presentations in outpatients that perhaps the dermatologists and so forth don't need to completely see, but which general practitioners might want some degree of support for in terms of, you know, how to manage, so that clinical question that might only take a short amount of time or a bit of reassurance. So, and that means it empowers GPs to keep doing all of that particular work, which is obviously skin work is a big area of our practice, and it also helps upskill, and it also helps save the hospitals having lots of presentations in outpatients, which could really be managed in general practice. And what we've needed to find is how do we have a store and forward, so it's asynchronous, a sort of store and forward platform. These kind of things we need to really think about. The other thing that's politically, because I do think that legislation and political will drive some of this. As I've mentioned before, the state and federal divide in legislation funding streams is really pernicious to the interoperability. We are trying to work on forms of pooled funding from state hospitals. We're trying to work on statement of works. We've seen how in COVID, and I think this has really enabled us in COVID, the general practitioners have been working with the state health departments, and it's kind of like been an awakening really about the relationships that are so important there to work across healthcare in this way. So there is an appetite from both state health department kind of bureaucrats and general practitioners, and even the feds, to build that relationship better and to build some funding streams around it. I remain a little bit concerned when I see large hospital outpatients wanting to send out chronic disease team care into the community to manage some of their outpatients to save them coming in all the time to hospital outpatient care. And what they do is they send out a whole multidisciplinary team, which is good, but you know what? They haven't included the general practitioner in there. And if we were funded, we could probably do it for a fraction of the cost of what the state hospital's doing it, but we're not recognised. So if we start building that collaborative care model, and then sometimes we have to lead, sometimes we can't do much until the funding follows us and the legislation follows us. So this is three very important areas. It's the implementation from us as clinicians, it's our leadership, it's the digital infrastructure that we need, it's the legislation, and it's the funding. So if we can get those things moving together, we will, I think, enable a much better level of patient care. Patients want to be cared for in the community, and as Chris said, being able to do that in the community without having to bring them into hospitals all the time is huge productivity savings, for a lot of patients, not having to take off, as you said, the whole day to go and attend outpatients. Yeah. All right. I'll leave it there because I could talk.
Thanks, Karen. And I'm going to flick over to Bernard now for your comments, particularly, as I say, at this stage, we're focusing on this collaborative care and the integration between the general practice role, which we all recognise to be the one that really understands the patient, and the specialists involved in the management. Thank you.
Thank you, Robyn. I think what would be nice is to have a real-time, secure, intuitive, comprehensive platform for all specialists, including GP and non-GP, to use so that we can work collaboratively. And then it has to start from the mentality of willing to work together instead of I work my bit and then I'll pass on to you, you do your bit and send it back to us. It's not like that. We need to have a bigger picture to see, the nephrologists probably want to see what the cardiologists are actually doing, and the cardiologists want to see if the physio is following up with the exercise, and then the GP will have that sort of overall view as the manager of the information. So we need to have this sort of technology platform for us to be able to have this utopia, if you may. And the UK sort of has that system already, and the US has one or two systems, and Hong Kong has just one system for all public services to use. And that it's not perfect, of course. When you have one universal system, there's always limitations. That you can't do this, you can't do that. but the basic is there. It's good enough. And I don't think we can ever have a perfect system, but we should not let perfect to trump progress. The innovation is a process, it's not a destination. If we start thinking about the process of how to innovate, how to move on to the next step, and that's probably where we should start, and then start experimenting different things. We won't get it right the first time. The My Health record is not perfect. We need to work on that and make it better and make it better and make it better. And that's the mentality we should have.
Thank you. I think there's an opportunity now for each of the speakers to provide some final comments, but two issues that have come up in the chat room that I'd like to cover. First of all, the simple one, there was a question about whether this recording will be available. And yes, I'm assured by, and I think Sophie has responded via the chat to say that it will be shared with all attendees after, give us 24 hours or more to get it up there, and it'll be shared with you. And it will also be available via the Telelcare website and YouTube. So that will all be the commentary. We might have a look at some of the questions I think have been very good, and whether we pick those up separate from the recording of this, we can look at that. The other really interesting issue, which each of the speakers might like to speak to, is the question, is there a recognized doctors association for telehealth, telemedicine that participants or interested GPs and specialists could join? If not, we should start one to make our voice loud and clear to the policymakers. Now, I'm sure Karen will speak to the role the College of General Practitioners has in this, and it might be, Chris, that this is something that Telelcare could advance further to in the work that we do. So can I ask perhaps Karen to first of all make some final comments, and also including addressing this question about how do we recognize that telehealth, video conferencing particularly, has some really valuable means of improving integrated healthcare. There are some stumbling blocks. There is no doubt that a major stumbling block is the issue of the state-federal divide, and I'm very jealous of those involved in the health system in Hong Kong, where there is genuinely one health service governing or political body. So a little bit about that, and over to you, Karen. Thank you very much.
Well, we have 34 national faculties of specific interest, and I haven't had a chance since you asked me that question 30 milliseconds ago to see if there is a digital health one. But what I would say is great. I heard Ray mention that there's a Telelcare Facebook group. Look, the communities of practice that we've built, like, you know, I'm also the founder of GPs Down Under, which has got 8,500 GPs on it. I mean, this is an issue that's central to every general practitioner and every doctor, clinician, nurse, allied health. This is a huge issue for all of us. So have the community of practice, but bring it out to the mainstream, because we all need to get digitally literate. The other thing, and my closing comment will be, the human factors will always trump the digital ones, so that we mustn't lose sight of that. And it's clear that the government wants us to proceed to video. There was this sort of tension that video had evidence for a better quality outcome, but I'm not convinced. I think there's different cohorts of patients and subgroup analyses that need to happen. That the implementation has shown that telephone is still the preferred option, because we've got the patients who need it, and the patients who need it the most are the inverse care law. And so human factors will always trump, no matter what our aspirations are. I mean, I love geeky stuff as much as anyone. A robot, hologram. If the patient on the other end can't manage it, then it's an implementation issue, and that's a human factors issue, which has all of those socio-cultural lenses around disadvantage in our community. So I'll leave it there.
Thank you very much, Karen. Chris, can I just hold you to the end and ask Bernard to speak? I know you've got lots to say. Sorry. Can I ask Bernard to speak next? Thanks very much.
Yeah, I don't think there is an official external associations or committee to get all the interested bodies together to run this digital health platform. But RACGP does have the practice technology and management expert group, which I'm also a member of, and so it's run by Dr. Rob Hopkins, and he's the real tech guru, and so any new technology on the market he would know about. He will be very interested in test them out, including the QR code, and he was part of the design and the implementations of what the Department of Health have been using for check-in and check-out at the moment. And so I also want to agree with Karen about how technology and telehealth, some patients really like it, and some patients actually prefer it because of their mental health. They didn't want to get out of the house, and some doctors, same thing, and some really hate it. So we need to bear in mind the value of face-to-face consultation cannot be replaced and cannot be ignored. The physical examination of a patient is still 50% of the information gathering process for us as doctors, and that's still what we do every day. And no technology can replace that sort of information and by collecting during the examination process. So the digital health can only augment what we do, not replace. And we need to do better, but we still treasure the time the patient sitting in our room and being able to have that consultation with us, and so that we can examine them properly.
Thank you very much for that very succinct summary of it. There is one particular question, Chris, that's come through to you, but yeah, so and this actually relates, it's addressed to Chris, and it's collaborative care with general practice. We need to make appointment earlier before the patient is in the clinic. We find some patients see specialists every few weeks and they find it exhausting. Can I just before you, no, that's okay. I'll pass over to you, Chris. Could you do a summary and perhaps include a direct response to that query? Thank you very much, or that statement.
Yeah, I just don't quite understand the question. If you could maybe elaborate a little bit more on that, Saga. I will just quickly speak. I'll get back to that statement, but I will just quickly plug the Facebook group, which I know you guys mentioned, Telehealth for Doctors, which is a small group, but we're hoping to grow it. And we do some prizes. There's some quizzes, giving away massive prizes. So if you want to look up that and join it, that would be great.
Sorry, Chris, just before we do that, sorry, what was the group? And can I ask Sophie or whoever's coordinating this, can we maybe send around an email to participants, giving them some information about some of these focused groups that exist out there in the community? So that's an ask of Sophie when we're doing the forwarding of the recording. Chris, back to you.
Yeah, no worries. So I'm just trying to understand what Saga is saying here. So yeah, some patients see specialists every few weeks and they find it exhausting. I mean, that's true, and definitely having a three-way call with the specialist and the GP and the patient is very challenging, just logistically setting things up, you know, to find the time when the GP, because often GPs or specialists could be running behind. So it is a logistical challenge. It's a bit of a nightmare, but and I don't think it needs to be for every single consultation, especially if the specialists are seeing patients very frequently. But for, you know, once in a while when you're making critical decisions, I think it is important. And I certainly have done many consultations with GPs and found it to be just very beneficial. So I know it's hard, but it is probably worth it.
Chris, that's your final comment. I'm very conscious of the time. We have been scheduled to finish a few minutes ago, but I'm informed that there's a bit of flexibility. Thank you. can I just conclude then by summing up to saying, I think we would all agree that the experience of being locked down during the COVID-19 pandemic with restricted access to face-to-face consultation has, for those of us living in the city, replicated the everyday experiences for patients and doctors residing in isolated rural communities. Furthermore, this COVID-19 pandemic has provided a wonderful opportunity to stimulate and to drive developments in collaborative care which is facilitated by digital technology. Now, we've talked about some of the limitations of that digital technology, but nevertheless, it's undoubtedly a development that will be advanced in the future. I certainly have found this morning session interesting, informative, and encouraging, fortunately, and I trust others have too. Our challenge now is to ensure that the momentum we have achieved, thanks to COVID-19, is not lost. I thank the three panelists for their great contributions. We've been extraordinarily fortunate to have the benefit of their experience and insight. So many, many thanks, Dr. Karen Price, Dr. Bernard Shiu, and Dr. Christopher Sia. Thank you very much. And that finishes this particular session. And I leave it to others to hand over to the next panelists. Thank you.